Good evening, everyone, and welcome to our Vestibular webinar series, Session 1, Vertigo Management. I'm Helene from WVPHN, and Jade is alongside me doing all the back-end stuff, and she's also a Workforce Development Officer. I'd like to begin by acknowledging the traditional owners and custodians of the land in which we're zooming in from today. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities. We pay our respects to both elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations, and we'll work together on closing the gap. Just a little bit of housekeeping. The majority of our webinars are recorded and freely available on our PHN YouTube channel. The link's on the screen at the moment. I have our upcoming events there also on the screen. You can register for these via our website. Jade will put that in the chat for you. Please make note of our PHN Health Pathways on the screen at the moment. That's relating to the topic this evening. If you have entered this webinar not displaying your accurate first and last name, can you just pop that into the chat box? The admin here, we're the only ones that will see your names, and this will just ensure that we get your name right so that we can record you with the RACGP. For this evening's webinar, all participants will be on mute. So if you have any questions, could you just type them in the question and answer box, and then I will ask them on your behalf to the presenter. It'll be all, I won't name names or anything. It'll just be, I'll just ask the questions. There's a link in the chat box to complete the survey. That's up on the screen at the moment. So this evening's speaker is Rosie, and she's the Director and Physiotherapist at Neurophysio Geelong. So thank you, Rosie. I will hand over to you to do more introductions.
Thanks, Helene. All right, hopefully that screen share has worked. Thanks to Helene, Jade and the PHN for inviting me to present tonight. I'm one of the directors here at Neurophysio Geelong. As Helene mentioned, our business opened almost 3 years ago, and we've got a clinic on High Street in Barwon with a really great team of neurophysios. So we've got 4 and soon to be 5 vestibular trained physios, and we enjoy seeing a variety of clients with vertigo and balance disorders in the subacute setting. I'd also like to begin by acknowledging and paying my respects to the Wadawurrung people, the traditional custodians of the land on which we are gathered today, and to pay my respects to their elders, past, present and emerging, and acknowledge all Aboriginal and Torres Strait Islanders here today. Also paying my respects to your elders, past, present and emerging. So this summary slide will show an overview of what we're going to cover this evening. So starting off with a brief review of vestibular anatomy and function, and then we'll launch into some common causes of vertigo. We're going to break up assessment into the setting of acute continuous symptoms or acute episodic symptoms, and we'll then look at treatment, management and referral options in the region. The learning outcomes were sent around prior, but essentially after the webinar, I'd like you to understand how the HINTS Plus exam applies in acute vestibular syndrome. And for those with episodic symptoms, how do we differentiate and then manage some of these conditions? Hopefully the diagram here looks a little familiar. This is the vestibular apparatus which resides in each inner ear. So as a whole, the vestibular system monitors head movement and position in space by detecting angular and linear acceleration. So the 3 semicircular canals detect angular acceleration. Each of these is filled with endolymph fluid, and a swelling at their base called the ampulla houses the cupula. The hair cells are located here with their nerve signals produced depending on movement of the endolymph either towards or away from the cupula. So these nerve impulses then run through the 8th cranial nerve, the vestibular cochlear nerve, to the brainstem, where they synapse within the vestibular nuclei and then send signals up into the CNS and into the cerebellum. So the output of this system is through ocular motor function via the VOR, or the vestibular ocular reflex, and also through influencing postural stability via the vestibular spinal reflex. So the utricle and saccule are the otolith organs, and they detect linear velocity and head tilt, and are responsive to gravity. So the otoconia, also kind of referred to as crystals, which we'll discuss later on when we come to BPPV, they normally live in the otolith organs where they have a really important function, for example, that help with sensing gravity. But they can cause mayhem if they dislodge and move into a semicircular canal. The most common causes of vertigo are in yellow and will be discussed tonight. Vestibular migraine is now the most prevalent condition causing vertigo, with a lifetime prevalence rate of 3.4%, compared to BPPV, which has a lifetime prevalence rate of 2.4%, but that increases to almost 10% by the age of 80. Acoustic neuromas are on the list, but they don't normally cause vertigo because they're usually really slow growing. So compensation occurs as they grow, but it is certainly something that we see in clinic as a comorbidity, or occasionally we pick them up new through the assessment process. It's worth defining the two main clinical syndromes that we're going to look at more closely tonight, just so that the language and the understanding is really clear. So AVS stands for acute vestibular syndrome and refers to a sudden onset continuous vertigo lasting longer than 24 hours with associated nausea and vomiting, all of which are worsened with head movement. And common causes of AVS include vestibular neuritis and stroke, usually of the cerebellar arteries, or sometimes just called the posterior circulation. And then episodic vestibular syndrome, or EVS, is an episodic dizziness, vertigo, or postural imbalance where there's remission between episodes. So it can then be diagnosed or divided, into spontaneous EVS or triggered EVS. And examples of the spontaneous type would include vestibular migraine, Meniere's disease, TIAs, and VP stands for vestibular paroxysmal. The triggered EVF examples include BPPV, orthostatic hypotension, and panic attacks. So you'd think that patients with symptoms as severe as the acute vestibular syndrome would go direct to ED, and often they do, but it's not uncommon for them to present first to a GP and even occasionally to a clinic like ours. So we're definitely going to kind of go through the differential diagnosis in that setting tonight. So we'll start off by looking closely at the assessment of acute vestibular syndrome. So previously in clinical practice, we spent time trying to differentiate the reported symptom, but research now shows that the client report is quite unreliable and time is much better spent focusing on the behaviour of the symptoms rather than the description. So this includes the temporal characteristics and their triggers. We all love a good acronym, and a useful one in vertigo assessment is TITRATE, which stands for timing, triggers, and targeted exam. So timing is really key. In the setting of AVS, if the acute onset starts while the patient is awake, a stroke might produce more sudden symptoms, whereas vestibular neuritis might build up over an hour or more. So knowing whether that gradual onset is sudden or a little bit more gradual is really helpful. That doesn't help if your patient has woken up with the symptoms. The other element of timing is duration. So in AVS, the symptoms have been continuous and persistent. And in EVS, symptoms may either be intermittent, like in BPPV, or continuous, but with known prior episodes. So it's something that's happened to the patient before. Triggers can also really help to diagnose. So in AVS, head movement will exacerbate symptoms like they do in BPPV, but they persist at rest, whereas in BPPV, we would expect the symptoms to stop when the head movement stops. So there can be lots of triggers in migraine. Some of these may have occurred prior to symptom onset, such as physical exertion, scrolling on a computer, or another kind of complex visual exposure. Less common third window conditions may present with noise or pressure triggered vertigo. And that can produce short bursts of vertigo like in BPPV. So the timing of the symptoms might be similar, but there's a clearly different mechanism when it's a sound or pressure triggered symptom rather than it being a head motion triggered symptom. In BPPV, head and body movements such as rolling in bed, sitting up or looking up, bending down are common causes of the vertigo that lasts usually for up to 30 seconds. When we think about some of the other conditions that we're looking at tonight, there's a lot of overlap between Meniere's disease and vestibular migraine, which we'll explore a little bit later. But both of these fall into the episodic vestibular syndromes, with Meniere's episodes tending to last from minutes to hours, and vestibular migraine anywhere from seconds to days. A targeted exam first includes the subjective assessment, with the key questions including, have you experienced anything like this before? Screening for cardiovascular risk factors, and also presenting red flags, which is on the next screen. And finally, the targeted exam, the objective exam, is performed. So the steps above have helped to identify whether you're dealing with an acute or an episodic vestibular syndrome. In the presence of acute vestibular syndrome and with spontaneous or gaze-evoked nystagmus, a HINTS plus exam is indicated. Whereas in episodic syndromes or with symptoms that sound more like BPPV, then positional testing is performed. So other neurological assessments such as strength, coordination, and reflex testing is also performed if a cardiovascular cause is suspected. So the red flags to look out for are subjective reporting of these symptoms and also objective signs when you assess. So brainstem signs such as dysarthria, dysphagia, drop attacks, diplopia, and progressive hearing loss, and upper motor neuron signs on examination like spasticity, clonus, weakness, any sensory changes, and particularly with the posterior part of the brain, looking at coordination and gait or limb ataxia. So let's look at the HINTS plus exam in some more detail, remembering that it's only indicated in the presence of acute vestibular syndrome with nystagmus. So the FAST stroke test, so face, arm, speech test, isn't sensitive for posterior circulation strokes. And the NIHSS doesn't include vertigo and dizziness, so that they can also miss posterior strokes. So we'll watch some videos next to see this in practice. But essentially, the HI stands for the head impulse test, which is a test of the vestibular ocular reflex, where you ask the patient to fix their gaze on a target while you move their head quickly and briefly to one side and then the other, and looking for the eye response. So we expect an abnormal test on one side in vestibular neuritis due to the damage that's occurred and affected the vestibular nerve on the one side. So having a positive head impulse test on one side is a reassuring finding in a HINTS exam, and the lack of a positive head impulse test is not reassuring and would point more towards a stroke cause. Gaze-evoked nystagmus looks for any involuntary rhythmic oscillation of the eyes in the primary position, so when the patient's gazing straight ahead, and when they're holding gaze partway to the left and partway to the right. So it's named for the fast phase. If you're looking at the eyes beating in one direction, you generally pick up the way that it's going really quickly, and that's the way that it's named. So for example, a right beat nystagmus is you'll see the eyes beating to the right. Actually, the vestibular component is the slow phase. So a right beat nystagmus indicates that the vestibular lesion is on the left side and normally matches up with a positive left head impulse test if it's vestibular neuritis. In vestibular neuritis, the nystagmus beats in the same direction in each position of gaze. So it's also called a unidirectional nystagmus or a direction fixed nystagmus. And in stroke, the nystagmus changes direction. So, for example, it might beat to the left in left gaze and then beat to the right in right gaze. But in vestibular neuritis, it would beat to the right in each position. The vertical skew test, so the TS, looks for vertical misalignment in primary gaze when each eye is alternately covered or uncovered. So with a positive finding, seeing one eye move up or down when it's uncovered. So this occurs due to a central vestibular lesion and is not expected in vestibular neuritis. The plus has been added to this testing regime over the last couple of years. And looks for any sign of new hearing loss. So basically you ask the patient to look straight ahead at your nose and you rub your fingers close together, close to each ear, asking you the patient to tell you when you're rubbing their fingers, noting any new unilateral hearing deficit. So new hearing loss can occur with a central or a peripheral cause, but it's the final sign that would trigger a stroke workup. So to diagnose vestibular neuritis, all elements of the HINTS plus must line up. So that means that you have to have a positive head impulse test on one side, a unidirectional nystagmus in all gaze positions, a negative test of skew, and usually, to avoid wanting to scan further, a lack of any new hearing loss. So you can have labyrinthitis where the cochlea is affected in the nerve damage as well, and that can cause new hearing loss, but that would kind of trigger a positive HINTS exam or a central HINTS exam with that finding. And it's quite uncommon, so it is worth exploring that further in the presence of new hearing loss. Conversely, a positive or a central HINTS exam suggests posterior circulation stroke in AVS when any of their signs are present. So you don't have to have all of the matching signs in the right-hand column to suspect stroke. Any of them is enough to indicate having a scan at the appropriate time. So the HINTS plus exam is more sensitive than MRI in the first 48 hours. So it's really a useful protocol to be aware of and familiarise yourself with when you have the opportunity. So here we'll just watch the HINTS exam in action. So just looking here at gaze-evoked nystagmus, the test of vertical skew, so looking for any up or down movement of the eye when it's uncovered, just screening for neck range before doing the head impulse test. And we'll see this in slow motion in a moment, but we're looking for the eyes moving off the target and then coming back with a corrective saccade like this to show a positive head impulse test, whereas when we move to the right, the eyes stay fixed on the target the whole time and the VOR is intact on the right-hand side. So just I probably repeat myself a little bit, but it is a worthwhile point to harp on about that the HINTS plus is to be used for people with AVS and nystagmus. Thinking about medical management of vestibular neuritis, there's a bit of conjecture in the literature. It's not 100% pro steroids, but I guess the thought is that early initiation of steroids for vestibular neuritis makes recovery of the vestibular nerve more likely, but obviously there are other factors to consider when prescribing steroids. And antiemetics are important to manage very severe nausea and vomiting, but they do delay habituation to the dizziness. So if they are needed, it's best to limit to short courses only. And if they can be avoided, then that's what we would definitely advocate for, so to help the patient make the quickest recovery afterwards. This is another representation of the TITRATE model for differential diagnosis of AVS. We won't go through it in detail, but I've popped it in as a reference and the article that it comes from down the bottom of the slide too, if you want to go back and look at that more closely. So we've covered a little bit about episodic presentations already, but we'll now look more closely at that and particularly comparing vestibular migraine and Meniere's disease, and then looking at the clinical assessment and management of BPPV. There's considerable overlap between Meniere's disease and vestibular migraine, and it poses a real diagnostic dilemma at times. So in Meniere's disease, abnormal endolymph fluid builds up in the inner ear and interferes with functioning of the sensory cells responsible for balance and hearing. The exact cause of Meniere's is unknown. So fluid in the inner ear is usually separate from the body's overall fluid system, and it contains specific concentration of elements such as sodium, potassium, and chloride. In Meniere's disease, the inner ear fluid volume and salt concentration fluctuates with the body's fluid levels, and over time, the abnormal concentrations cause permanent damage to this system. Just to make it more difficult, people with Meniere's disease are twice as likely to experience vestibular migraine, so having them as comorbidities is not that uncommon. But where possible, being able to differentially diagnose the two is really helpful because the medical treatment is quite different. Vestibular migraine is a central disorder, whereas Meniere's disease is a peripheral disorder. And vestibular migraine has got a really wide array of clinical presentations. So it can include migraine headache with or without an aura. It can include vestibular symptoms. So 38 to 80% experience vertigo with or without a headache or cochlear or oral symptoms. So the International Classification of Headache Disorders defines definite and probable vestibular migraine. For definite vestibular migraine, you must meet the following criteria. So having more than 5 episodes of vestibular symptoms lasting anywhere from 5 minutes to 72 hours. Having a current or a history of migraine according to the criteria for migraine. Having at least one migraine symptom during at least 50% of the dizzy episodes. So that can be either headache, photophobia, phonophobia, or visual or any other aura, and other causes ruled out by appropriate investigations. So that's the definite vestibular migraine, and then a probable vestibular migraine can have either 2 or 3, but doesn't need to be both. We definitely often hear clients describe a sense of pressure in their head more than the severe headache that characterises a typical migraine. Okay. So here's just a table kind of contrasting the two and also showing a fair bit of overlap. Vestibular migraine is much more common in females, with the average age of onset around 40 years old. So most, but not all, patients with vestibular migraine have experienced typical migraines in the past, with the average time between a typical migraine diagnosis and a vestibular migraine diagnosis being around 8 years. Meniere's disease, on the other hand, affects men and women equally, with the typical age of onset 40 to 60 years old, but also can be as young as 20. Family history and past medical history are 2 important features. A personal, like own history or family history of motion sickness is more related to vestibular migraine, whereas a family history of migraine doesn't help differentiate between the 2 conditions and can be present on either side. Vestibular migraine, people are more subject to in vestibular migraine, being more subject to motion sickness suggests that there's a hypersensitivity to a visual vestibular mismatch in this population. Migraine symptoms, such as visual changes and sensitivity, can also occur in either condition, but more commonly in vestibular migraine. And oral symptoms, such as tinnitus, a sense of fullness in the ear, or noise sensitivity, can also occur in both conditions, but more commonly occurs in Meniere's. Fluctuating hearing loss during a Meniere's attack does aid differential diagnosis, but usually needs to be confirmed with a hearing test to differentiate it just from that sense of kind of oral fullness. The symptom quality and duration can overlap, but episodes lasting longer than a day would be more indicative of vestibular migraine. Meniere's disease episodes tend to sit in the hours range. Clinical assessment of nystagmus with and without visual fixation also helps with diagnosis, with Meniere's generally producing a more classic peripheral or horizontal pattern, whereas migraine can produce any pattern but tends to be more low velocity. So you can see that that's all a bit grey. Definitely the vestibular migraine is far more common as a condition than Meniere's disease. In the past, Meniere's disease has really been over-diagnosed, but it's not so common to see anymore. So we're going to talk now about BPPV, or benign positional paroxysmal vertigo. If I guess kind of being familiar with assessing and treating BPPV is really worthwhile. And having a crack at treating BPPV and working off the hypothesis that it's probably in the posterior canal, because most of them are, is really helpful. So a single Epley manoeuvre, which we'll go through in a minute, has equivalent effectiveness to 10 days worth of Brandt-Daroff exercises and is much less traumatic for the client to experience. So Brandt-Daroff exercises aren't recommended anymore, and certainly we would recommend, if you are comfortable completing a Dix-Hallpike test and then doing the subsequent Epley manoeuvre to treat it, that's really will give your patient a head start in getting rid of their BPPV. There's a comprehensive list of contraindications to a Dix-Hallpike assessment included in the appendix of this talk, but essentially the patient needs to have 45 degrees of neck rotation and 20 degrees of neck extension to perform this safely. As I mentioned before, the incidence of BPPV really increases a lot with age, and only about 20% will resolve spontaneously at a month. So it's a real problem. By 3 months, 50% will have resolved spontaneously. But there are a lot of complications that can occur from untreated BPPV, such as falls, fractures, reduced quality of life, and mental health concerns. So certainly, the earlier the treatment, the better. Okay. After posterior canal BPPV, which accounts for up to 85% of cases of BPPV, the horizontal canal is the next most common. We're not going to go through horizontal canal assessment tonight, but it's useful to know that it exists. So if your patient sounds like they have BPPV, but you can't actually pick it up on the assessment, it's definitely worth referring to a vestibular physio to look at it more closely. The most cases of BPPV happen for no reason. So it can sometimes be associated with trauma, with migraine, with other inner ear problems, diabetes, osteoporosis, and immobilization. So in the incidence of being really unwell or having had a big surgical procedure, but there's often no link. So we're going to have a look at the Dix-Hallpike assessment. So we're going to run through what this looks like. So the patient's head is rotated 45 degrees to one side, so in this case to the left, and then in one way or another, you lie the patient down to get their head into 20 degrees of extension. So in this scenario, we've got Catherine lying with pillow behind her to get her, and her head then hangs over the back of the pillow. You can also have your patient positioned so that their head goes over the end of the bed. We have now got plinths where the top third of the plinth extends downwards, and so we can keep the patient's head on the plinth and control the extension a little bit more that way. So a couple of points about the Dix-Hallpike assessment. You always want to be able to assess both sides before you treat one, because bilateral BPPV, whilst uncommon, can occur. And in that instance, you want to treat the more affected side first, so to have been able to compare the two sides. So if you have any clues from the subjective assessment as to which side is more likely affected, for example, if somebody tells you that their symptoms come on every time they roll over to the left-hand side, but it's not so bad when they roll to the right, then they're probably affected on their left side, in their left posterior canal. And I would assess their right Dix-Hallpike first to make sure to rule it out, and then sit the patient back up again before you turn their head to the left-hand side and lie down into the left Dix-Hallpike position. So I've heard quite a few times about healthcare professionals assessing the first side properly, and then if that's negative, just rotating the head to the opposite side while the patient's still lying down. but that won't provide accurate information. And to stimulate the canal properly, you do need to sit the patient back up again and then rotate their head the other way and then lie down. It's really important that that sit to lie is part of the Dix-Hallpike procedure. And so when they're in position, we'll see in a moment what the classic Nystagmus looks like in BPPV, but basically we're looking for a combined upward and torsional Nystagmus. So here we go.
This Dix-Hallpike test is testing the left ear, which is the downward ear. It is strongly positive, which is diagnostic for posterior canal BPPV. When she is placed in the Dix-Hallpike position, nothing happens for the first 3 seconds. And then... Dizzy. You can see it there. I'm very dizzy. She becomes very vertiginous and has vertical upward nystagmus with a rotatory component towards the downward ear, which is the left ear. It lasts around 15 seconds. Is it sort of gone away now? Yeah. In slow motion, you can see the upward movement of her pupil, as well as the rotation of her eye, where the upper poles are beating towards the left ear, the downward ear. This is, again, a classically positive Dix-Hallpike test and diagnostic for posterior canal BPPV.
So that's a really nice example of typical posterior canal BPPV nystagmus in the Dix-Hallpike position. Like I included in the AVS, this is the model, the TITRATE model for episodic vestibular syndrome. Again, just included more for your reference to come back to later on if you want to do some more reading on this topic. Okay, let's have a look at treatment and management of some of these episodic conditions. So sticking with BPPV, we're going to have a look at the Epley positioning manoeuvre. So we've started off in the Dix-Hallpike position, which is the first position of the Epley manoeuvre. So like in the previous video, I brought Catherine from sitting in, popped her head in 45 degrees rotation, and then we're laying down into the Dix-Hallpike position. With a positive test is the nystagmus, like we just saw in the other video, and then we're going to move through the Epley manoeuvre. Okay, so in BPPV, the short arm of the posterior canal, it's the most gravity dependent where the cupula resides, and the cupular barrier, if you remember from the first diagram, or you can see it in here as well, blocks the otoconia or the crystals from exiting the posterior canal. And so to exit the posterior canal, the otoconia have to be moved all the way around the posterior canal, away from the ampulla towards the common crus, which is that intersection of the anterior and the posterior semicircular canal, so it can exit back towards the utricle. So this is performed using the Epley manoeuvre, which is the most commonly known technique. There are many other repositioning manoeuvres, but if you're familiar and confident with both the Dix-Hallpike and the Epley, then you can treat the majority of BPPV cases. So let's watch that now. So we're going to move into the second position in a moment. So rotating the head 90 degrees so that we end up looking 45 degrees to the right and staying in that 20 degrees of extension. Okay, so we stay in that position. People aren't normally symptomatic in the second position, but we still stay there for 60 seconds. The video is a sped up version, so I'll pause while we talk, and then we roll into the third position where she's lying on her right hand side. The head essentially stays in the same position, but it moves 90 degrees with the body, and so she'll end up looking towards the floor. Oops. So people often are dizzy again in this third position, which is a good sign that the crystals are moving. So wait for the dizziness symptoms to stop, and then at least another 30 seconds, if not a minute. And then you can sit back up. So keeping the head rotated while you sit up, and then you can bring the neck back to neutral once the patient's back in sitting. Okay. So the next few slides were presented by Dr. Alex Chen in our vestibular migraine webinar last year, and he's given me permission to share these this evening. But given that they are it's a medical nature, I'm not going to too much detail on this front, but I did want to include it as a resource, knowing that many of you joining tonight are prescribers. As physiotherapists, we provide a lot of advice and education around the modifiable lifestyle factors when it comes to managing vestibular migraine, to identify and address the relevant triggers in order to improve the overall condition. So, for example, encouraging regular exercise, education around sleep, dietary advice, such as staying well hydrated, drinking 2 litres of water per day, having regular small meals rather than having big meals more spaced out with the aim of trying to keep the blood glucose levels more stable, avoiding any known food triggers, having a higher consumption of fruit and vegetables, legumes, fish, and a lower consumption of fried food, processed meats, and soft drink. There's a bit of mixed evidence for salt intake, but I guess if this is identified as a trigger, then definitely something to reduce. Medical management for migraine is separated into meds that can be taken at the onset of symptoms, so ablatives, and meds that for prophylaxis that aim to reduce the overall frequency and severity of attacks. So ablative choices are going to differ depending on the primary symptom, knowing that some people with vestibular migraine don't experience a headache, and what they need might be more targeting their vertigo. That's going to depend on a case-by-case basis. This is, again, a list of medications that can be used in vestibular migraine, and some of the considerations depending on any other comorbidities that may be present. For Meniere's disease, often one or both of diuretics and SERP or beta histine are used. So the diuretic with the aim of regulating the fluid in the inner ear, and the beta histine goal is to improve blood flow to the inner ear. Looking at vestibular rehab, many vestibular conditions will benefit from vestibular rehab, which differs from kind of specific BPPV treatment, for example. So the rehab approach incorporates gaze stability exercises, movement and visual habituation exercises, and balance training exercises and education. It's based on the principle that some kind of error signal is required to stimulate the compensation process in the vestibular system and reduce the symptoms of vertigo and imbalance felt. Persistent dizziness is a whole nother talk on its own, and it's going to be the topic of the third webinar in this series, which will take place early next year. But I guess my message tonight is that there is really proven effectiveness of vestibular rehab in many vestibular conditions, both central and peripheral. And getting this rehabilitation done early on really can reduce the likelihood of progressing to a more persistent and disabling condition. For clients who are willing and able to pay for private treatment, our clinic keeps an urgent vestibular or concussion appointment available every weekday. So patients with acute vertigo can generally be seen at very short notice. So some of the reasons that you might think about referring somebody on from your care might be if you've diagnosed vestibular neuritis and you want them to have some rehab following that infection. For BPPV follow-up, if the symptoms haven't resolved in the next couple of days after your treatment, or if you think it maybe a different canal has been affected. New vestibular migraine for education and habituation exercises. For further assessment, if the cause of vertigo is unclear and you've ruled out an acute kind of central condition or other medical diagnosis. And the falls and balance assessment or treatment, again, if a medical cause has already been ruled out. I know that people watching see patients from all walks of life. Not everybody has the financial means to access private practice, and I do want to provide a comprehensive list of referral options in Geelong and further afield. The audio vestibular clinic at Barwon Health is a really fantastic service. It mainly operates as an assessment clinic. I've popped a referral link in, but if you can't kind of click on that, I don't know how that really works when you access the slides, but you can easily find the referral details when you Google the clinic name. For clients who don't necessarily need the dual discipline assessment, so the audiologist and the physiotherapist, referrals also can be made directly to vestibular physio at the community rehab centres in Geelong as well. This is the same slide that I included in the 2021 webinar. I can't swear to its currency, but it will provide a good starting point if you're situated more rurally and need to find a provider closer to where you are. There is a list of both public and private services, so hopefully that helps as a starting point if you're looking for somewhere in your region. Other referrals, audiology is often needed for people who are presenting with vertigo and balance disorders. They can do, obviously, just straightforward audiograms can be found lots of different places, but certainly at the public hospital here in Geelong. And at Macalla Centre, they've got specialised clinic for their vestibular function tests, which is really great to have that accessible to us so quickly and easily. There are a number of Geelong-based neurologists and ENT specialists who are very capable in the area of vertigo management. And then I think it's useful to know that the Meniere Hospital in Melbourne has got the Omniax clinic, which is capable of treating refractory cases of BPPV or, ruling in or out BPPV as the cause of somebody's vertigo as well. Through the same hospital, you can access neuro-otology and neurology as well through the public system through their balance disorders and ataxia clinic. There are also a few private specialists working in the vertigo field in Melbourne whose details are there. Dr. Lewis Tang is currently completing his fellowship with David Schmulewitz at the Meniere in Melbourne, and hopefully will be consulting down here next year, which is very exciting. He is going to join us for the persistent dizziness talk at the start of next year, but hopefully will be another person to add to this list as time goes on as well. Here are the references and a few suggestions if you're wanting to learn any more about vertigo management. I'm happy to take any questions. Thank you very much.
Okay, thanks, Rosie. That was a fantastic presentation. We're so lucky that you were able to do that for us. I don't have any questions, so please, if you've got any questions, anyone, pop them in the question and answer down the bottom there. You'll see Q&A, so you can pop any questions relating to the topic or anything that you think you might want to ask Rosie. Take the opportunity to do that at the moment. I'll give you a few minutes to type something in if you wish. Don't forget to do your evaluation. Okay, question. Thanks, Rosie. Do you do the EPLI for both sides?
No. So you would only do the EPLI manoeuvre for the side which you've identified as the affected side. If you were unlucky enough to find somebody with bilateral BPPV, so for example, they had a positive Dix-Hallpike test in the left and the right position, then certainly you would want to treat them on both sides, but we would only do one side per session. So normally, treat the worst side first and then come back the next day to do the other side. And in answer to that next question that I can see, we do an EPLI more than once within a session. So our standard practice is to do the EPLI manoeuvre, let the patient just sit quietly and rest for 5 minutes, and then we reassess them and repeat the manoeuvre if it's still positive. Do you charge any gap fee for physio? Yes, we do. Yep, we're a private practice, so we have the EPC referral gives them a $56 rebate, but there's an out-of-pocket fee to pay as well.
Okay. Any more questions? Pop them in there. Got a few minutes. Anything you want to finish up on, Rosie?
I don't think so. I appreciate that this is a really broad kind of topic. So hopefully you were able to stick with me. The other two webinars in the tri-series that we're presenting this time around will be concussion in a couple of months' time, and then persistent dizziness early next year. So both of those, I guess, allow us to sink our teeth into one topic instead of trying to do a very broad overview, but it's useful to just have a bit more of an introduction to Vertigo today. So hopefully that was okay.
Excellent. Okay. Got a question here. What position should you leave the patient in post Epley? For example, try not to move head.
No, so in general, unless someone has had problems with really recurrent persistent BPPV, we would have them, so they sit up out of the Epley maneuver as the last position, and then I just have them sit quietly for 5 minutes and then tell them to go about their day as normal. If they were going to go to yoga or gymnastics or something like that, I would say to avoid that for the day. But, only for 24 hours, really, thinking about not inverting themselves. But other than that, it's, life as normal, because there are, I guess, in the research that's looked at that and whether precautions post the Epley have found more problems by people avoiding movement and being fearful of movement than benefits. So it's no longer recommended as a standard.
Thank you. Okay, if there's no more questions, we'll finish up the webinar. Thank you again, Rosie, and thank you for everyone to attendance, and we'll see you at our next meeting. Bye, everyone.
Thank you.